Welcome to the Dr. Izzy's Medical Podcast channel.
Graves' disease. Graves' disease, also known as toxic diffuse goiter, is an autoimmune disease that affects the thyroid. It frequently results in and is the most common cause of hyperthyroidism. It also often results in an enlarged thyroid. Signs and symptoms of hyperthyroidism may include irritability, muscle weakness, sleeping problems, a fast heartbeat, poor tolerance of heat, diarrhea, and unintentional weight loss. Other symptoms may include thickening of the skin on the shins, known as pretibial myxedema, and eye bulging, a condition caused by Graves' ophthalmopathy. About 25 to 80% of people with the condition develop eye problems. The exact cause of the disease is unclear, however, it is believed to involve a combination of genetic and environmental factors. A person is more likely to be affected if they have a family member with the disease. If one twin is affected, a 30% chance exists that the other twin will also have the disease. The onset of disease may be triggered by physical or emotional stress, infection, or giving birth. Those with other autoimmune diseases such as type 1 diabetes and rheumatoid arthritis are more likely to be affected. Smoking increases the risk of disease and may worsen eye problems. The disorder results from an antibody, called thyroid-stimulating immunoglobulin, that has a similar effect to thyroid-stimulating hormone. These TSI antibodies cause the thyroid gland to produce excess thyroid hormones. The diagnosis may be suspected based on symptoms and confirmed with blood tests and radioiodine uptake. Typically, blood tests show a raised T3 and T4, low TSH, increased radioiodine uptake in all areas of the thyroid, and TSI antibodies. Signs and symptoms. The signs and symptoms of Graves' disease virtually all result from the direct and indirect effects of hyperthyroidism, with main exceptions being Graves' ophthalmopathy, goiter, and pretibial myxedema. Symptoms of the resultant hyperthyroidism are mainly insomnia, hand tremor, hyperactivity, hair loss, excessive sweating, oligomenorrhea, itching, heat intolerance, weight loss despite increased appetite, diarrhea, frequent defecation, palpitations, periodic partial muscle weakness or paralysis in those especially of Asian descent, and skin warmth and moistness. Further signs that may be seen on physical examination are most commonly a diffusely enlarged, non-tender thyroid, lid lag, excessive lacrimation due to Graves' ophthalmopathy, arrhythmias of the heart, such as sinus tachycardia, atrial fibrillation, and premature ventricular contractions, and hypertension. People with hyperthyroidism may experience behavioral and personality changes, including psychosis, mania, anxiety, agitation, and depression. Causes of Graves' disease. The exact cause is unclear, however, it is believed to involve a combination of genetic and environmental factors. While a theoretical mechanism occurs by which exposure to severe stressors and high levels of subsequent distress such as post-traumatic stress disorder could increase the risk of autoimmune disease and cause an aggravation of the autoimmune response that leads to Graves' disease, more robust clinical data are needed for a firm conclusion. Genetics causes. A genetic predisposition for Graves' disease is seen, with some people more prone to develop TSH receptor activating antibodies due to a genetic cause. Human leukocyte antigen DR appears to play a role. To date, no clear genetic defect has been found to point to a single gene cause. Genes believed to be involved include those for thyroglobulin, thyrotropin receptor, protein tyrosine phosphatase non-receptor type 22, and cytotoxic T lymphocyte-associated antigen 4, among others. Infectious trigger. Since Graves' disease is an autoimmune disease which appears suddenly, often later in life, a viral or bacterial infection may trigger antibodies which cross-react with the human TSH receptor, a phenomenon known as antigenic mimicry. The bacterium Yersinia enterocolytica bears structural similarity with the human thyrotropin receptor and was hypothesized to contribute to the development of thyroid autoimmunity arising for other reasons in genetically susceptible individuals. Epstein-Barr virus is another potential trigger. Mechanism: Graves' disease. Thyroid-stimulating immunoglobulins recognize and bind to the thyrotropin receptor, which stimulates the secretion of thyroxine, T4, and triiodothyronine, T3. Thyroxine receptors in the pituitary gland are activated by the surplus hormone, suppressing additional release of TSH in a negative feedback loop. The result is very high levels of circulating thyroid hormones and a low TSH level. Diagnosis of Graves' disease. Graves' disease may present clinically with one or more of these characteristic signs. Rapid heartbeat, 80%. Diffuse palpable goiter with audible bruit, 70%. Tremor, 40%. Exophthalmos, protuberance of one or both eyes, periorbital edema, 25%. Fatigue, 70%, weight loss, 60%, with increased appetite in young people and poor appetite in the elderly, and other symptoms of hyperthyroidism, thyrotoxicosis. Heat intolerance, 55%. Tremulousness, 55%. Palpitations, 50%. Eye disease with Graves' disease. Thyroid-associated ophthalmopathy, or thyroid eye disease, is the most common extrathyroidal manifestation of Graves' disease. It is a form of idiopathic lymphocytic orbital inflammation, and although its pathogenesis is not completely understood, autoimmune activation of orbital fibroblasts, which in thyroid-associated ophthalmopathy express the TSH receptor, is thought to play a central role. Hypertrophy of the extraocular muscles, adipogenesis, and deposition of non-sulfated glycoaminoglycans and hyaluronate, causes expansion of the orbital fat and muscle compartments, which within the confines of the bony orbit may lead to dysthyroid optic neuropathy, increased intraocular pressures, proptosis, venous congestion leading to chemosis and periorbital edema, and progressive remodeling of the orbital walls. Other distinctive features of thyroid-associated ophthalmopathy include lid retraction, restrictive myopathy, superior limbic keratoconjunctivitis, and exposure keratopathy. Management of Graves' disease. Treatment of Graves' disease includes antithyroid drugs which reduce the production of thyroid hormone, radioiodine, and thyroidectomy, which is called surgical excision of the gland. As operating on a frankly hyperthyroid patient is dangerous, prior to thyroidectomy, preoperative treatment with antithyroid drugs is given to render the patient euthyroid. Each of these treatments has advantages and disadvantages. No one treatment approach is considered the best for everyone. Treatment with antithyroid medications must be given for 6 months to 2 years to be effective. Even then, upon cessation of the drugs, the hyperthyroid state may recur. The risk of recurrence is about 40 to 50%, and lifelong treatment with antithyroid drugs carries some side effects such as agranulocytosis and liver disease. Side effects of the antithyroid medications include a potentially fatal reduction in the level of white blood cells. Therapy with radioiodine is the most common treatment in the United States, while antithyroid drugs or thyroidectomy are used more often in Europe, Japan, and most of the rest of the world. Beta blockers, such as propranolol, may be used to inhibit the sympathetic nervous system symptoms of tachycardia and nausea until such time as antithyroid treatments start to take effect. Pure beta blockers do not inhibit lid retraction in the eyes, which is mediated by alpha-adrenergic receptors. Antithyroid drugs for Graves. The main antithyroid drugs are carbimazole, in the UK, methimazole, in the US, and propylthiouracil, PTU. These drugs block the binding of iodine and coupling of iodotyrosines. The most dangerous side effect is agranulocytosis. Others include granulocytopenia and aplastic anemia. Patients on these medications should see a doctor if they develop sore throat or fever. The most common side effects are rash and peripheral neuritis. These drugs also cross the placenta and are secreted in breast milk. Lugol's iodine may be used to block hormone synthesis before surgery. Radioiodine treatment. Radioiodine was developed in the early 1940s at the Mallinckrodt General Clinical Research Center. This modality is suitable for most patients, although some prefer to use it mainly for older patients. Indications for radioiodine are failed medical therapy or surgery and where medical or surgical therapy are contraindicated. Hypothyroidism may be a complication of this therapy, but may be treated with thyroid hormones if it appears. The rationale for radioactive iodine is that it accumulates in the thyroid and irradiates the gland with its beta and gamma radiations, about 90% of the total radiation being emitted by the beta particles. Disadvantages of this treatment are a high incidence of hypothyroidism, up to 80%, and requiring eventual thyroid hormone supplementation in the form of daily pills. The radioiodine treatment acts slowly, over months to years, to destroy the thyroid gland, and Graves' disease-associated hyperthyroidism is not cured in all persons by radioiodine, but has a relapse rate that depends on the dose of radioiodine which is administered. In rare cases, radiation-induced thyroiditis has been linked to this treatment. Surgery, thyroidectomy treatment. This modality is suitable for young and pregnant people. Indications for thyroidectomy can be separated into absolute indications or relative indications. These indications aid in deciding which people would benefit most from surgery. The absolute indications are a large goiter, suspicious nodules or suspected cancer, and people with ophthalmopathy, and additionally if it is the person's preferred method of treatment or if refusing to undergo radioactive iodine treatment. Pregnancy is advised to be delayed for 6 months after radioactive iodine treatment. Advantages are immediate cure and potential removal of carcinoma. Its risks are injury of the recurrent laryngeal nerve, hypoparathyroidism, due to removal of the parathyroid glands, hematoma, which can be life-threatening if it compresses the trachea, and relapse following medical treatment, infections, and scarring.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.